So today I'm going to talk about Morton's neuroma. Probably a lot of you have heard of this and or think you have it or know somebody that does, and maybe that's why you're watching. So hopefully this will help you. I'm Dr. Meredith Warner, and I'm in Baton Rouge, Louisiana. Also licensed in Texas and Mississippi, originally from Delaware. And I'm the founder of Warner Orthopedics and Wellness, and we have a philosophy of total care of an individual, not just one single musculoskeletal body part. In other words, we don't break you up into parts like elbows, fingers, left pinky fingers, second toe on the left foot, medial part of your right knee. We look at you as a whole person, metabolically, hormonally, nutritionally, your social factors, and your musculoskeletal package as a complete package, and then take care of you and help you optimize and get better. We sort of specialize in age management, you could say. So these are some of our services, not all of our services, but sort of gives you a smattering or sort of a, I guess, an appetizer of what we have to offer here. We are about to start up our group wellness program to include yoga, and we're going to have seminars, workshops, classes, private classes, etc. Some of those I'll teach, and certainly I'll give the academic background of the yoga and how it's important for physical human health. We have a podiatrist who's amazing, Dr. Kyle Lindo. We have an amazing esthetician, PA, certified PA, Sarah Balladares here with Smooth. We do functional massage, we do fascial stretching, fascial massage, we do dry needling. We've got amazing physical therapists. They actually keep my surgical schedule lighter than probably most, because we treat and cure so many people non-operatively here successfully, and we're happy to do so. So we also offer things like IV infusions if they're indicated, infrared spa heat treatment, which is an awesome way to lose weight, improve skin health, and sort of improve your circulation and general health and well-being, things like that. So think of us as your total wellness solution, and let's get started learning about Morton's neuroma. This is just some images of my clinic, and here we go. So what is Morton's neuroma? Probably some of you have heard of this. So one thing you need to understand about orthopedic surgery is, for whatever reason, doctors like to have their names attached to bad things. So Dr. Morton got his name attached to this particular issue. I hope that you never have a Warner condition, because I don't want my name attached with anything bad. But Morton's neuroma is essentially felt as pain in the ball of the foot. So forefoot, it's a forefoot problem you can think of. It's commonly between the third and the fourth toe. That's the most common location, but sometimes it'll be in the other web spaces. Pain is often felt if you're in anything that improves or I guess increases the impact on the ball of the foot. That's why we think of high heels, things like that. People that are toe walkers probably are prone to this. But it's also associated with foot deformities such as hallux valgus, bunions, hammer toes, flat-footedness, anything that alters the normal, what is considered natural architecture of the foot, which is designed to hold the human body upright and to balance our weight. If that changes, then you can get a Morton's neuroma. So it's a biomechanical problem, but it's also really a neuropathic problem, and I'm going to explain that in a minute. Okay, so what do I mean by neuropathic? Well, the term neuroma is probably not technically a correct term for this condition, but we've been using it forever, so it's probably not going to change. A neuroma is really a tumor of a nerve or an abnormal growth of a nerve. That's a technical definition. This isn't really what Morton's neuroma is. It's actually a neuropathy. It's a type of nerve pain, sort of like diabetic neuropathy, alcoholic neuropathy, or any kind of entrapment neuropathy like carpal tunnel, ulnar tunnel syndrome, tarsal tunnel, cervical disc, lumbar disc. All of those are like entrapment neuropathies. So you could think of Morton's neuroma that way. It's just simply a single digital or nerve to a toe in the foot that gets entrapped, and then that hurts. That's because nerves don't like to be squished. Think of it that way. They don't function well in a smushed position. They like to be free, like we all like to be free, right? Next slide. Okay, so just to give you an idea of the way pathologists and, like, you know, when you get into the super basic science, how we think about this, the picture on the left is a Morton's neuroma, and the picture on the right's a normal nerve. These are when We send the nerve, after we resect it in surgery, we send it to pathology. They freeze it, slice it up, stain it with different things, and look for certain types of tissue. So the Morton's neuroma's got a lot more fibrous stuff around it. It's just not quite right. It's not as neatly beautiful in its architecture as the normal nerve is on the side, on the right. You can see there's less nuclei, so they're less healthy. The nerves and the cells aren't functioning right in a Morton's neuroma as opposed to a normal nerve. And this is just more evidence that it's probably neuropathic and rather than a true tumor. So who is Dr. Morton and what did he actually think? And why do we think of it as a neuroma and not a neuropathy when it's really a neuropathy? Well, come to find out, back when he described this in 1876, he actually called it a, quote, painful syndrome of the fourth metatarsophalangeal joint, end quote. What's the metatarsophalangeal joint? So metatarsal bone, phalanx. So the metatarsophalangeal joint is the joint between the long bones of the forefoot or the arch and sort of what you consider your toe, which is the phalanxes. So that joint, the metatarsophalangeal joint, is the ball of the foot. Every toe is positioned in the ball of the foot and they have a fat pad under it to protect them, and that's the ball of the foot. So he was actually just describing pain in the ball of the foot, not a nerve problem itself. And then even before he put his name on this and it became Morton's neuroma, it had been described, but the terms used then were a painful clinical syndrome of the forefoot. So again, really we're talking about pain and neuropathy, not a neuroma, but it's gonna always be called Morton's neuroma. That's why we're gonna continue to use that term, but just so you understand the real problem, and then maybe you'll understand how to prevent it better and then how to treat it better. So think of it really more like an entrapment neuropathy. Okay, so what does Morton's neuroma feel like? So how do you know you have a Morton's neuroma? Most people, that's a great question because I hear all kind of different descriptions of this. Some people say it feels like there's a sock balled up in their shoe. Some people say they feel like they're walking on a rock. Some people say their toes get numb. Some people say there's a dull, aching, throbbing forefoot pain. Some people feel it with push off. Some people only feel it when they wear their high heels. Really can feel like anything. And so my rule of thumb is if it's a vague complaint that doesn't really make a tremendous amount of sense, it's probably the nerve. So basically, if you're currently feeling as though there's a pebble in your shoe or a balled up sock, or it just feels like there's a water balloon, or it's just kind of like a foggy or numb, tingly kind of a feeling, you may have this condition. So what would make you get this condition? Or would make you not get this condition? So what are the risk factors? So like everything else in podiatric medicine and orthopedic surgery that deals with the foot and ankle, everybody wants to blame high heels. I don't personally ascribe to that theory, but what a high heel will do is think of it this way, and then you're like this, and your metatarsophalangeal joints are extended, and you're putting a tremendous amount of pressure on the fat pad of the ball of your foot, and also on, guess what, the nerves. So of course, anything that puts you like this can make you feel the pain of any given neuropathy or entrapment problem more. So I think high heels just sort of bring out the symptoms, not that there's so much causative. And then ill-fitting shoes, meaning if you're wearing shoes that jam up on your toes, you're getting like, you're losing toenails periodically or getting bruises or calluses or hammering, or they're tight this way, right? Then of course you're gonna have some issues. The foot deformities like we talked about, bunions, things like that, anything that changes your foot from being a tripod. So your weight's supposed to be on the heel, the first metatarsophalangeal joint, the fifth. And then it's supposed to be balanced amongst three arches, okay? With the plantar fascia sort of tensioning all of the forces throughout. If anything disrupts that, you could get any of a host of problems in the foot and ankle, one of which is, of course, Morton's neuroma. And then tight Achilles tendon. So this is Achilles, which is your calf muscle, okay? The heel cord. If that's tight or contracted, look what it does to the forefoot. Automatically, you're going to have more pressure on the forefoot. So anytime you have a tight heel cord, which it's estimated something like 90% of Americans have tight heel cords, you could have forefoot pain. Okay, and this shows you that biomechanics. This is a force vector diagram of the heel cord. Any engineers out there will understand this better than I do. But basically, the forces of the body are distributed evenly. Everything has an opposite and equal force to balance it out. So when you lift up and you apply that muscle force, plus you have your weight, you have the normal force of the earth pushing back, and it's an equal amount. And so you're going to have the same amount of force as your weight and the muscle activity pushing on your forefoot. And so it's important to keep flexibility in your hind foot at your heel cord. It really helps the forefoot. I love this bottom picture on the right. It shows you what I'm talking about when you're wearing high heels. And if you're able to wear high heels like this lady is, congratulations. I personally can't because my feet are just too wide and that would hurt me. But you see how hyperextended her metatarsophalangeal joints are, right? So obviously there's going to be more pressure at this point, more contact pressure than the person on the other side who's in, I guess that's a Doc Martin, which is a little bit more neutral. So that shows you the risk factors and why you might have more pressure on the forefoot. And anytime you concentrate the same amount of force in a smaller area, that increases the contact pressures, which increases the force. And our tissues like fat, skin, muscle, bone are designed to withstand a certain amount of force, and that's just too much for them. And then that causes pain, particularly if you have an entrapment neuropathy. Okay, so how can you prevent it? If you have it or you think you have it or you think you're developing it, or let's say you have a job where you have to wear high heels. Some of us do, and it is what it is. Try to wear healthier shoes for your foot, or less painful, I should say, when you're not at work. Look for footwear with a firm, supportive sole. One of the reasons I wear Danskos to work, is a plug for Danskos, I guess, is because it's very firm and rigid, which is very healthy for the foot. And it's got this nice curved rocker, which takes pressure off of your metatarsophalangeal joints. Avoid high heels if you can. If you can't, understand. But in the meantime, you should stretch your heel cord, do some deep tissue massage. We'll get into that later. Do things to counteract that position. It's kind of like all of us are like this nowadays at a computer, or we're texting, right? So we're forward cross X. So every now and then you need to do this to counteract those constant forces. So you can wear high heels. You just need to do the opposite and protect your foot when you're not in it. So stretching the heel cord is hugely important. And then offloading the metatarsal head. So when I designed the healing sole, I put this metatarsal bar rather than a big arch support for a couple of reasons. But one of the reasons was to offload the ball of the foot, okay? And then also it's on a rocker bottom, right? These are stiff shoes on purpose. They eventually break in and then they don't feel nearly as stiff, but this is by design, it's healthier. And it offloads a ball of the foot. So that combination is why I did that. And it's because of the principles behind all of this, okay? You got to offload that entrapment area to at least reduce the pain. It's not going to cure it, but it can help manage the symptoms. Okay, and here's the arch structure of the foot. So you have the longitudinal arch, which is what probably everybody thinks of as the arch, sort of the inside curve of your foot. But there's also a transverse arch, which is very important and nobody thinks about. The transverse arch is like this. That's an exaggeration, okay? But as we get older, we splay out like this and oftentimes end up like this, which is a reverse transverse arch. And guess what happens? More pressure right where you don't want it. So you also have to consider the transverse arch. And then there's actually also supposed to be a small longitudinal arch on the outside part of your foot by the pinky toe. This picture of the Roman bridge on the right side shows you how important arches are for distributing weight and tension. And that's why we have them in our foot, obviously, because guess what? Your foot has to distribute weight and tension all the time. So think about the ground reaction forces, think about your transverse arch, think about the tripod structure of the foot, and think about an entrapped nerve in that situation, and you start to understand the importance of all of this. So this picture is showing a deformed foot with a bunion, and you can see muscle atrophy, sort of hollows between the tendons that go to the toe. And you could imagine that this individual not only has a bunion, but is losing or has lost the transverse arch, okay? Anytime you have a prior toe amputation, it can lead to distribution of forces that are different. Knee flexion contractures, or let's say you just had a total knee and you haven't gotten all your range of motion back, well, that can lead to abnormal forces on the forefoot. Hip arthritis, a huge cause of abnormal forces on the foot. Hip stiffness, psoas tightness or hip flexor stiffness. And a million reasons to have abnormal pressure on the forefoot. Not everything is a quote unquote Morton's neuroma. It's rather what Morton really described, right? A painful condition of the fourth metatarsal phalangeal joint. And that's really also what I call lateral forefoot overload syndrome. And anything can cause that. So you really have to understand the true cause of your forefoot overload and then manage it that way. And here's showing you more schematics. You can see that transverse arch on the right cartoon of the foot there, and how normally the space between 3 and 4 and 2 and 3 should be higher than where your weight should be, which is 1 and 5. And as that arch flattens, that's when you start getting that pressure between the 3rd and 4th toe and the 2nd and 3rd toe, which are the most common sites of this, right? And then this shows you the picture with the green bone and the sort of the cross section of the bone looking like you're looking from the middle of the foot towards the toes, shows you how that exactly mirrors the Roman arch construct, right? It's pretty cool. And that alone is able to support all of your weight all day long. It's pretty amazing if you think about it. But sometimes it goes awry or there's problems. And then when you lose that sort of passive ability to bear weight without constantly flexing and extending your foot muscles, that's when you start to have problems. Okay, so let's talk about treatments. So there's some older methods of treatment that are still ongoing, and then there's some newer things, and then there's some alternative treatments. Invasive, I think of invasive like surgery. Probably injection should also be considered invasive. And then there's a lot of non-operative treatments. So to specifically talk about injections, let's talk about steroids. Still the standard of care, still done, I don't know, 1 billion times a day, probably globally. The biggest thing for your purposes to understand about steroid injections is not only are they well within the standard of care, but most insurance companies pay for these. They also pay for alcohol injections, I believe, or ablative injections, you would consider it. The outcomes of steroid injections, though, in my opinion, are somewhat questionable to justify the risk. So 50% of people that get a steroid injection still go on and need surgery, okay? And that's within 2 years. Now, some people might think it's worth it to get a steroid injection to have up to a year of pain relief, but I think the side effects don't warrant it, particularly when there's other safer methods of treatment that are just as effective. The side effects include skin depigmentation, and I've seen this often, atrophy of the muscles in these web spaces, atrophy of the fat pad, death of the fat pad, and that's like you can't reverse that. If you get that, that's forever. And there's really no treatment except for very expensive fat graft injections, almost like fillers for your facial fillers. You can do that, but other than that, there's really no great treatment. So for me, I do steroids in very, very rare instances if there's literally no other thing I can do for somebody because of the risk factors, and I just think the benefits don't really justify them. And I just don't want to mess with changing the DNA of their cartilage and connective tissue in that zone, in the nervous tissue, for up to a year, which is what steroids do. They act on the DNA and change the way the fibrocytes work, et cetera, et cetera. We can get into that in another talk if you like. But anyway, the downsides to surgery, let's talk about that. It's expensive. If you have a high deductible, you know what I mean? And a lot of us have high deductibles nowadays. A lot of us have co-insurance, co-pays, whatever. So surgery's A, not cheap, and B, you have opportunity costs of surgery, right? Anytime you have surgery, you're going to lose work time. You're not going to be productive. You're going to have a period of basically no wealth creation. Think of it that way. So extensive recovery time after a surgery. And some people, this changes surgeon to surgeon. If I do a Morton's neuroma resection, I usually let people go to work the next day if they want to, and weight bearing is tolerated. But some surgeons have a different protocol. So if you think you need surgery or you're about to have surgery, you may want to check on the post-op protocol and make sure that it's going to fit your work and your lifestyle. And then injections, you have the side effects we talked about. Also, some people have what's called a cortisone flare. And this is when the steroid actually crystallizes in the tissue. And so it becomes tiny microscopic crystals, and that actually causes more pain. And that can last anywhere from a day to a week after an injection. Usually goes away, but obviously you don't want to get an injection and hurt worse for a short term, but that happens to some people. It's rare, but it does happen. And there's no guarantee of surgery, no guarantee of steroids. Once you pay for those and once you have them, you can't back out of that. It is what it is. And so if it doesn't work, not only do you have the problems of the injection, but you also have the problems of the surgery if it doesn't work. And that can be anything from a scar to wound problems or whatever. I mean, no surgery is without complications. So I think you need to think that through before you go invasive with treating a Morton's neuroma. I think you should look for the source of the neuropathy or the mechanical overload and fully exhaust those treatment options first. So what are some alternatives? So CAM is complementary and alternative methods of treatment or medicine. The picture on the right is supposed to depict acupuncture, but this could actually depict dry needling too. A very validated, excellent method of physical therapy for this problem. My physical therapists do things from treating hip immobility all the way down to doing dry needling in the foot to try to treat these neuropathic conditions of the forefoot. The other picture shows sort of the chi theory of where the foot relates to the rest of the system and the energy flows of the body. So that goes along the lines of like reflexology, acupressure, acupuncture, more of the Eastern methods of treatment. Also, thousands of years of history of excellent results, so you can't argue with that, and probably much safer than steroid injections or surgery. But every now and then somebody does need surgery, obviously. So newer methods of treatment, there are some drugs that are being looked at that the FDA is trying to approve or fast tracking for approval. One of these is a synthetic capsaicin molecule. So you can't patent nature. Capsaicin is from the chili pepper. But if you figure out a way to make a mimicking molecule in a lab, you can make a patent on that and then go get FDA approval for a pharmaceutical. And if you do that, and then all of a sudden no one else is allowed to use capsaicin in the same way. So it's kind of a tricky way to block out the natural stuff. But these are some drugs the FDA is looking at. The alcohol injections we talked about. The problem with that, in my opinion, is it takes so many, 1 to 9 injections, okay, weekly. So think about that. An average of 6. And it's you putting in dilute 4% ethanol, okay, which is like 96% alcohol or whatever. And it works by injuring the nerve with dehydration, necrosis, and the precipitation of protoplasm. In other words, it makes the cells sort of granulate and explode, I guess you could think of it that way. Well, it's not just doing this to the nerves, it's doing it to all the tissue around it. So I personally don't do this, but it's a valid treatment. A lot of people do this, and a lot of people have success with this. The literature shows it's about 30 to 50% successful. But again, steroids are 50% successful if you really look at the literature critically. And then let's talk about surgery. So the picture on the top right is a specimen of an actual nerve removed. The long part on the right side of the picture is the common digital nerve coming from between the metatarsals. And then that kind of gloppy thing is where it's been entrapped and compressed under the intermetatarsal ligament. That's your neuroma. And then the 2 little sprigs at the end show you where the little branches going to the lesser toes are. So that's what we actually go in, find, cut, and remove, and send to the pathologist to look at so that you get those microscopic pictures we showed at the beginning of the talk. And then the one on the left shows you the surgery happening. And then the one top picture, the cartoon, shows you sort of an image of the entrapment. So that band of tissue is the intermetatarsal ligament, and that is where the nerve gets entrapped, okay? And then it just becomes abnormal because of that entrapment. So what can you do short of surgery? Well, based on everything I've told you so far, you could probably already figure this out. Take pressure off of this part of your foot, right? Any which way you can is the first thing. And then try to reduce your inflammation in general so that your nerves function better. Reduce your oxidative stress so that your nerves function better. And then wear shoes that don't irritate the condition, if you have the condition. So this talk is not meant to be a ban on high heels. I still wear high heels periodically, but if they hurt, I take them off. So that seems like a logical thing to do. The other thing you can do, I brought this to show you. I often recommend shoes like this. This is an Ultra. The reason I like this shoe is it doesn't have that constrictive kind of pointy shape most running shoes do. It's sort of foot shaped. But more importantly, it's what's called 0 drop. So most shoes are elevated at the heel, about 12 degrees or so. down to the thing, forefoot. And remember, I already told you, most people have contracted heel cords. Most people already forefoot overload. So a 0 drop sort of redistributes your weight automatically. It's more like standing barefoot. So it takes pressure off the forefoot. So 0 drop shoes, anything with a metatarsal bar, a metatarsal pad like we talked about. And the reason that's important is twofold. Not only does it offload the ball of the foot or the metatarsophalangeal joints, okay? But if you have a good met pad and it's placed in the right spot, it'll actually increase your transverse arch that we talked about. So there's a bunch of different mechanical ways to fix the problem because it's a mechanical problem at the end of the day in combination with a neuropathic condition. Okay, so anything you can do to reduce inflammation of the nerve and offload pressure, you're gonna get better. Short of that, then you go to things like injections or surgery. Hopefully not, but it does happen. Okay, so here's some stretches that you can do that work not just on the plantar fascia, but also will reduce pressure on the intermetatarsal spaces and the ligaments. Because remember, the plantar fascia comes past the metatarsophalangeal joints and sort of vertically integrates, connects the forefoot to the heel to give you the tension band of your arch. So anything you can do to stretch this, okay, either pulling with a towel before you get out of bed, rolling your foot on a tennis ball, or if you can tolerate it, a lacrosse ball, and if you're really in the mood for a deep tissue massage, a golf ball. Anything you can do to kind of stretch the muscles, and this one's showing you pulling up on the big toes specifically, and that really pulls on the plantar fascia and stretches things. And then heel cord stretching is very important too. All of that is going to make your forefoot have less load, be more flexible, and more able to handle those normal forces of the ground. This is the ball roll we're talking about. That's probably a lacrosse ball. They're a little bit firmer than a tennis ball, so it's a little bit more painful. Probably starting with a deflated tennis ball is the way to go if you're in a lot of pain. And then you just kind of gradually graduate up. This is what I was talking about with the metatarsal pads, placed to increase the transverse arch and also offload that second and third and fourth metatarsal heads. And then rocker bottom soles, age-old treatment, right? Works great because it takes pressure off of your forefoot. So when you heel strike, the shoe rocks for you and you don't have to push off quite as hard. So rocker bottoms are a great option as well. And you can actually, if you have a cobbler in your town, you can get a shoe modified with a rocker bottom. Or you can buy shoes that come with them already. I put a small rocker bottom in my healing sole for this principle alone. And it's an excellent treatment method. And this shows you how it works. So you have a metatarsal bar that takes that pressure off the forefoot, combined with a rocker bottom sole, and then the metatarsal bar. And those three things will mechanically offload the forefoot. But you can do this with custom inserts too. You don't have to get the healing sole, although obviously I love it. But I just want you to understand the principles of how to take pressure off your forefoot. And the one thing you can do for yourself that'll help you more than anything else is stretch your heel cord. If you don't know how to do that, go talk to your physical therapist and let them get you started. So what about other alternative methods of treatment? Well, one treatment, believe it or not, is high-dose B1 and B6, or thiamine and pyridoxine. Why? Because one of the theories is it's a neuropathic condition, right? And so you improve nerve health with B vitamins, but also D vitamins, and there's a lot of natural herbal remedies that improve nerve function. The Well Theory's pain cream, I designed it because I wanted essential oils that promote lower oxidation levels or oxidative stress, lower chronic inflammation levels, and improve healing capacity. And a lot of these plant-based herbal natural therapies do that. So there are some topical things you can do that can help with nerve pain. There's actually an 8% prescription capsaicin patch that your doctor can order if all else fails. There's some lower grade capsaicin lotions you can get over the counter. You can get this one, which has turmeric, menthol, the essential oils, and also PEA, palmitoyl ethanolamide. This is a fatty amide that your body produces naturally that is produced anytime a nerve is irritated. So anytime there's inflammation around a nerve and the mast cells around the nerve just degranulate and release all of their irritating cytokines, PEA comes in and calms all that down. So if we add PEA, you can reduce pain. But don't forget the B vitamins too. And then other antioxidants and natural herbal remedies are like, I have some patients that are on medical marijuana for chronic intractable nerve pain. There's a lot of herbal alternative remedies out there that are my opinion, probably healthier and better than steroids, certainly healthier and better than narcotics, probably safer than injections. Don't forget physical therapy. Physical therapy is an amazing treatment for neuropathic conditions, especially forefoot pain. And people don't think about it, but your foot is a musculoskeletal entity connected to other musculoskeletal entities. So a lot of people have no foot core strength, no balance. They've lost their tripod. Their heel cords are too tight. Their hips are too stiff. They've got knee issues. They're not walking optimally. So there's a million things a physical therapist could fix. And then all of a sudden your forefoot pain goes away. So basically, I kind of gave you a lot about Morton's neuroma, but it is a lot more than it sounds like. There's a lot more to it, a lot more behind it. And you might think you have a nerve tumor or a Morton's neuroma, but it might be just that your nerve is too tight as it crosses the knee, and that might be a simple fix. And hopefully that helps you. And if you have any questions, feel free to ask them.
My second and third toe on a foot with the bunion is numb. Is that, and that foot also has plantar fasciitis.
So somebody in the audience just asked if in the setting of a bunion plus plantar fasciitis, if the second and third toe are numb, is that what this would be? And I would say more likely than not, yes. Because when you have a bunion, not only do you have this deviation of your big toe, but this bone sort of lifts and rotates and does what? Puts more pressure on these guys when you're walking around. And then, of course, if you have an entrapment neuropathy and you've got this deformity and then also a contracted plantar fascia, you're going to really irritate these structures and you can get that numbness and pain. So in order to fix that, you got to sort of correct the whole package, if you will. All right. Just waiting to see any more questions. Otherwise, hopefully you have a good understanding of this and you can probably self-treat a lot of it. And if not, feel free to come see us or wherever you are, your provider of choice. But don't forget physical therapy, and some chiropractors are very awesome at treating foot pain like this too. Or even acupuncture, or even just a foot massage sometimes can help. Don't forget the zero drop shoes, offloading, metatarsal pad, metatarsal bar, and stretch your heel cords. Most important thing that you can do for yourself.
Sandy said she's coming to see you.
All right, Sandy's coming. We look forward to your visit. And that's it, short and sweet. Take care, y'all.
Oh,
Wait,
one last second
question.
Could you talk about nerve burning?
Nerve burning. Could I talk about nerve burning? I could talk about nerve burning for probably a week. I love treating neuropathic pain. I don't know why. It's just very interesting to me. Burning nerves is basically the nerve is firing uncontrollably on its own. We call it ectopic firing. And your brain perceives that as burning. That's that neuropathic condition, okay? So entrapments cause that, poor nerve function, oxidative stress to the nerve, damage from sorbitol or the byproducts of advanced glycation end products from diabetes and excessive blood sugar. All of this damages the integrity and structural ability of the nerve to function as a nerve, which, remember, all a nerve is a wire. It's an electric conduit between sensory organs and the brain, which interprets everything and then tells you what you're feeling. So you have this aberrant electrical signal that's sending the wrong message to your brain, and your brain feels burning pain when there's nothing going on down there except the nerve is off kilter. So that's why I like to find the source of the neuropathy, if there is one. And if it turns out to be just a mechanical entrapment, I like to address that rather than just masking it with pills if we can get away with that. But that's what burning is. That is a, almost, I would guess you could call it a red flag of a neuropathic condition.